So we've got a session today on telemedicine, the future is here, principles and practice. And the session includes an overview of the challenges and considerations of developing a sustainable telemedicine system. And we have a case study from the Airedale hub and an overview from St Luke's Hospice in Sheffield about their technology. I'm delighted to introduce all four speakers. I'm going to introduce them in turn as they speak. I'm particularly excited to see my Airedale colleagues again. I retired from Airedale a couple of years ago, so I'm pleased to see Richard and Linda back. So I think Richard's going to start. Richard Pope, trained as a physician specialising in diabetes and endocrinology, and worked as a consultant at Airedale Hospital in West Yorkshire until 2012, holding posts as medical director and director of research. His long-standing interest in the use of information technology in healthcare, with a particular emphasis on its potential to transform care delivery. And as well as being one of the earliest proponents and adopters of cross-organisational shared electronic patient records, he pioneered the development and routine clinical use of video conferencing in England and has led Airedale's Hospital's highly regarded programme of work in this field. He's now clinical director with Dynamic Health Systems, and I'm going to pass over to Richard.
Thank you, Chris. Good morning, everyone. Oops, there we go. My brief this morning is really to act as an aperitif for the main course, which is sitting on my right. And really what I want to do in a few minutes is to give you a very personal view of what is an exploding field with thousands of health apps out there, health technologies, most of it rubbish, and with enormous potential to cause confusion and fragmentation in the health system. So to really focus on what are the challenges from a personal perspective and some of the considerations we might want to put in place as we try and develop these systems. And of course the e-health system we're focusing on is teleconsultation, and if anybody thinks that this is new, then have a look at this. This is from a French magazine of at least 100 years ago. And how accurately did they predict the future? So they said in the year 2000 there'd be video conferencing and that people would be able to have their conversations through a link. They got it wrong by 20 years, which is not bad. And if you look at the little box in the top left-hand corner, they even invented the wireless router. So whatever we do, it isn't new. Okay, but we're talking about innovation, and there are two types of innovation. I'm sure you're well aware of this: incremental innovation and disruptive innovation. Over 90% of what we do in this area is incremental. It's taking the established business model, the established systems, and just tweaking them to move them forwards a little bit. But what we absolutely desperately need is disruptive innovation, and this was recognized by Department of Health a few years ago in the long-term condition compendium, that we all know services are not sustainable unless we fundamentally change the approach that we're adopting to deliver care. And this is tough. The speakers have all been bemoaning this outside this morning. It's a hard road to follow this, but it's one that's very worthwhile, as we'll show you. And it seems to me that certain types of innovation are dealt with in an almost schizophrenic way by the NHS. So there are new treatments that come out with RCT support, and immediately the whole organisation jumps left and changes tack. But if you have an approach that's sort of dealing with the fundamentals of how a clinician and a patient, a client, interact with each other, it seems far harder to get the service to adopt those things at scale. And people rather glibly say it was a cultural thing. But all too often I don't see the next thing was, well, whose culture and why? And some work that with Dynamic Health Systems and Sue Ryder, Claire Pearson, who's in the audience today, we've been looking at this from the patient's perspective, because I'd suggest it's certainly not the patient's culture that is resisting change. So these are just some comments from 400 or 500 comments that we got from a series of focus groups from people. And you can see the theme is clear. People want a different model of care that is more focused around their needs, far more responsive than current systems seem to be, avoids duplication and so on. And these are things that we're all familiar with, but the system seems to still want to resist change. So why might that be? Well, a chap called Zeleny a few years ago talked about disruptive technology and saying, well, what is the disruption? And he suggests that the disruption is actually in the technology support network. So it's not the change itself that's causing the problem. It's the impact that that change may or may not have on the infrastructure that's around that. And I certainly recognise that when I saw this statement from the work that I've done in recent years, where people say, well, you know, what's it going to do to my job plan? It's going to give me more work. You know, how do I manage my clinics differently? It's those sort of support things that people resist. And you finish up with this sort of thing, where you feel as though the NHS is pulling you back with a great big piece of elastic. A bit like walking down the waterfront this morning, and sort of leaning into the wind, thinking, actually, it's a bit like this. And I actually took the decision after a long time in the NHS to cut the ties and break out and try and develop things at a more rapid pace and then bring it back into the NHS, because it is genuinely very hard to do it within. So there are other things as well, and of course there's an academic science around this, around change management and behavioural economics. People's fear of the potential loss of something outweighs what they fail to see as a potential future benefit. And also I think there's a really deep-seated thing that, you know, we were taught to clerk people, to take a history in a particular way. We were taught to examine somebody in a particular way, to gather the information we're going to use to make clinical decisions. And that seems to be really deeply rooted in our psyche. We seem to struggle to find new ways of doing that and to accept those. And of course there's a whole series of academic things around that, which we haven't got time to go into today. But these are all forming part of the resistance to change. And then there are other things as well. We were speaking to somebody who was a life coach, a psychologist by background, and she said, you know, it's really interesting. I do a lot of work with consultants. And when you do Myers-Briggs profiles on them, a lot of them, far more than you'd expect, have an ISTJ profile. And I said, well, what does that mean? She said, it means they don't get big picture. So I've been going along at Airedale and saying, you know, we've got to change the world, and half the outpatient clinics can disappear, and we can do it in a different way, and people just sort of going pale and falling over. And actually people genuinely struggle, if they have that personality profile, to accept big change like that and the vision of big change. You have to deal with those individuals differently. You have to take them in very small steps with giving them a lot of security around each of those steps in terms of the governance, the evidence, and so on. And you have a disruptive change, but you increment that change in small steps that they feel comfortable with and can then come with you on that journey. Second thing, again, a personal observation, is I don't think the mainstream NHS understands development. And what I mean by that is that if you're looking at development in this term, you're talking about starting from nothing and actually building a product, building a technology from ground up. And that's quite different to what we do when there's a new drug treatment that comes into play, where the phase 1 and phase 2 trials are just unseen by the NHS. It's phase 3 when it really comes in. So there have been 6, 7, 8, 10 years of work, if not more, under the water. And so people can come with oodles of evidence, which gives people confidence. And that doesn't happen with development. I've seen 3 things in my career so far where developments have nearly failed because people have struggled to accept they haven't got 100% reliability day one from a technology-based intervention. And that leads into the third point on there, which is show me the evidence. So you go along and say, well, we've got a new way of working. Oh, that's really exciting. Show me the evidence. You say, well, actually, it's new, so we have to build the evidence as we go. Yeah, that's really great. Show me the evidence. And you get stuck in this awful loop. And a colleague of mine, Professor Mohammed from Bradford, talks about the research in this area being formative, not summative at this stage. So what we're actually describing in the research that's going on is not the outcomes, it's how do you deploy this stuff more effectively, and what are the sort of steps that you can take to shorten that journey time. And I think there are new types of research activity. I don't think we're going to see the traditional RCTs in this area because the refresh rate of the technology outstrips the ability to do an RCT. And we saw this in the telehealth area with a whole system demonstrator a few years ago, where by the time it was published, the technology was 4 generations further on, and the cost base was completely different. And so the conclusions that the RCT drew were not applicable to what you would deploy today. And I think that's a challenge that we have to work through and build the evidence in real time because you're collecting that evidence from the technology system that you're deploying. So the potential to do different sorts of research is there. So how can you do it? Well, just again, personal perspective, design an outcome, not a gadget. Don't build it and they will come. Work out what the outcome you're trying to achieve is and design a technology or a service to deliver that outcome. Choose your initial use case very carefully. You want to choose something which is sufficiently common that it's important and it's relevant, and that the change you're going to make will be a meaningful change in the eyes of the stakeholders, but not something that is absolutely mission critical, where if you get it wrong, because you will, initially, that it brings the whole pack of cards down. And similarly, you have to choose your technology even more carefully. It's really important to try and look over the horizon and make sure that you're going to bring in a technology that is standards-based wherever possible, so that you've got longevity built into your system. There's nothing worse than having a bespoke operating system, for example, that is not going to be relevant by the time your product is going to go to scale, your service is going to go to scale. And obviously, but often forgotten, understand the implications your approach may have on people, both patient side of the fence and professional side of the fence, the services those people run, the organizations that they represent, and the system as a whole. And to do that in a series of domains, whether it's safety, obviously the critical thing, and clinical outcomes, but also experience, and again, experience on both sides of the fence. What will it do to capacity? And very importantly, what will it do to financial flows? Now, I'm not saying that you should be constrained by these. It's absolutely okay to disrupt, but you have to understand where your problems are going to come from and where people are going to object, and try and work out a strategy of how you will address those things as you move through. And having done that, you build your team. And then start. Most of these projects will start with a very small-scale proof of concept. There's a lot of sweating goes on at this stage. That's why I put the picture from Airplane, the movie, in. You have to actively manage the project. It's not just going to happen by itself. You really have to be on top of this every minute of every day, and expect that you'll fail. I've reached a point now where I'm a little bit more zen-like about this, and you know that you're going to go over here and then realize you've made a mistake, come back, and then gradually you refine, and then the whole thing accelerates away. And as you go through that process, you have to question everything. What do I mean by that? I'll give you an example in a little while, but things are going to go wrong, and the answers to why things have gone wrong may come from a very left field position. And keep talking. You have to talk to your team, you have to talk to the stakeholders. This is a very fragile little sapling which has to be nurtured to get it to grow. When I originally wrote this slide, I actually put 2 talks down, and I thought actually saying talk was probably not a good idea just at the minute. So talk. And then you get through the proof of concept stage, you've got to scale up. That's another challenge. You need to develop champions, and champions from each stakeholder group. You need a finance champion, you need a governance champion, you need a technology champion, you need a patient champion, you need a relative champion. Build that coalition. And funding is going to be a challenge at this point, and you'll probably still be dealing with what I've called funny money. It'll be a project, it'll be time limited, and I think there obviously is a lot of funding in this space at the moment within the NHS, and it's great that it's there. But again, think about how you're going to move from that point to mainstream, and in order to do that, you will need to collect the evidence. And in collecting the evidence, it will take far longer than you expect it to. So be ready for that. Do your baseline work before you start. And you need to get people to keep the faith. You need to get boards in organizations to understand that it's going to be a couple of years before you've got meaningful numbers and therefore meaningful evidence. The ramp up, if you're lucky, the ramp up will be rapid, but it's more likely that it will be very slow, and it'll almost be an exponential curve. And that brings 2 challenges. First of all, keep the faith when it's running slowly, and the ramp up is going slowly, and Claire and I are working on something at the moment where that's happening. But we know that when we hit the inflection point, things will then change very quickly, and that brings a different challenge of how you're going to respond to the very rapid increase in numbers, which I'm sure Linda will mention in relation to telemedicine at Airedale. And the final point that we've experienced is that there's this big valley between hobby and mainstream. So you start off with these things, you can do the odd teleconsultation at lunchtime, or I'll just do it at the end of my clinic, and that's great because everybody's able to do that. And then there's an awful valley that you go through where there's more activity than you can comfortably manage in that way, but not enough to fill a full session. And it's certainly not mainstream at that point. And my advice to you would be push really hard through that. Get more people to use the system. Don't wait for the valley to close itself off and come back up again. Push through that point as fast as you can, because it's a very disruptive period. It's a very difficult period to manage. And through this, continue to question everything. Again, I'll come back to that in a second. Remain agile, because you're still sort of moving around to find your sort of final path with this. And think about transformation as a different thing. Think about transformation as being possible in units of 1. What do I mean by that? Well, if you transform the way that service is delivered for Mrs. Jones, you've absolutely transformed her experience of healthcare. If you transform a practice's use of technology, you've transformed it for 6,000 people, but you've done it in a unit of one. And I think we sort of expect that we can take the whole system at one step, and you can't, but you still achieve transformation. Don't be put off. Keep the faith. So what about a real journey? Just want to sort of highlight at very high level some of the things that we did at Airedale. We started the telemedicine work at Airedale in the prison service, using prison healthcare as the exemplar and delivering outpatient and A&E type consultations into prison healthcare using technology. And in the bottom, I must point out that the man in the picture there, the patient, is actually a shopkeeper from the village of Grassington. He's not a prisoner. But this is just to show you the technology that we were using at that point. So that was a telephone line-based connection. The kit cost £24,000. It was much bigger than this lectern, and it worked fairly well, but not all the time. And the quality, the picture quality wasn't brilliant. And we also had to dig the road up to get the telephone lines into the place. So, here's a real example of how technology has moved on so much in a 10-year time frame, and the cost base has just plummeted. So what you've got today will not be where you're at when you're at mainstream. We then went on to see if we could do the same thing into people's homes, and we used grant funding that we got from the Technology Strategy Board with a technology company in the Bradford area to develop a television-based system. So this was running through the patient's own TV at home. And you can see the kit there is a sort of set-top box, and that's a television that I'm speaking to a patient at home with. The question everything thing is that at some point in your technology project, there'll be a near disaster. And what happened is I was getting really good experiences. I'd do a clinic on a Tuesday morning, and I'd do a walk-in patient, then 2 telemedicines, then another walk-in patient. This is fantastic, got the future here. And my colleagues would say the thing never works. It fails, it freezes, it drops the calls, and so on. And we said, well, I couldn't understand it. The project very nearly went. There would have been no telemedicine hub at Airedale. And we were having a discussion about this one day, and the IT bods were in the room. And I said, I can't understand this. I said, these calls are failing all the time, and we've got this fantastic fibre network in the hospital. And somebody, wait a minute, it's not running on fibre. It's running on a telephone line. And so it was coming from the switchboard about 400 metres down the corridor and passing over photocopiers and X-ray machines. And of course, somebody would turn the X-ray machine on, the call would go. And the minute we switched it to fibre, the call reliability went up. So you really have to go back to first principles when things are not working. And it's easy to forget that. We had a system that could be used in a single location, we had a system that could be used in the home, but to scale that up, we had to make the finances work. And there's this thing about looking comprehensively at the drivers and the barriers. And to make the financial model work, we realized we had to get to a multi-occupancy setting where people were using the service fairly frequently. And it turned out that that was care homes. And in the care home setting, the whole principle seemed to be much easier to sort of sell to colleagues and to potential users of the service. But in order to do that, we had to build a 24-hour facility. And in order to do that, we had to revisit the staffing model. And the staffing model moved from a medical model to a nursing-led model. And Linda will talk about some of this and some of the results in a minute. And even then, it required the partnership with a technology partner into a joint venture that the hospital formed with them to kickstart the program and build the 24-hour facility. And Linda will talk about some of the details and some of the outcomes that come from that. So it's quick. Well, it's not. This was a 7-year journey before it really started to take off. And if you look in the literature, people even talk about it being a 17-year journey from first recognition of a new way of doing something through to mainstream implementation of technology. I think this is a little bit quicker than that, and Skype and FaceTime have made a massive difference to the acceptability of teleconsultation in people's eyes, both colleagues and patients. This is Justin Tuggy, who's taken over at Airedale as the digital health lead and is driving things forward with Linda and colleagues. So just summarising then, this is not something you undertake and have an easy ride with, but it's absolutely worthwhile, as you'll see. And when you're doing this, you really need to understand the why, what, how, and how much before you start. You must believe the outcome is worth the pain, because you will go through some pain as you get there. And the best way to minimise that is to build a coalition of willing partners as you go, and very much learn to speak each other's language. So engineers and medics don't speak the same language. We don't understand the same thing, if we use a particular term, and you have to learn to cross those sector boundaries, and when you do, there's a marvellous cross-pollination that happens, because an engineer will come in and say, well, we've been doing this way for 20 years, and think, gosh, that's brilliant, and vice versa. And once you've done all that, then just get going, okay? Because at some point, you have to bite the bullet and just start. And when you start, you very quickly build the sort of evidence that we'll now hear from Linda. Thank you.
So thank you, Richard, for describing the journey at Airedale. And now we move on to an example of collaborative working with a hospice. Linda Wilson is a consultant in palliative medicine at Airedale Foundation Trust. She trained as a GP and then joined the Yorkshire training scheme, gaining both her consultant qualification and a master's degree in palliative medicine. She's currently working with Sue Ryder-Manaland's community specialist palliative care team, and as well as telemedicine, her areas of special interest include motor neurone disease and service development for people approaching the end of life. So I'm going to hand over to Linda, who's going to do a talk and a video, I think.
Yeah, video in the middle. So I'm going to talk to you about the Airedale Digital Care Hub, as it's now called, and some of the work that we've been doing with them. So what is the Digital Care Hub? Well, really, at its simplest, it's a team of experienced, compassionate and very caring senior nurses who work 24 hours a day to cover the telephone and the telephone lines. And they, at the moment, are providing two main services. They're providing telemedicine, as discussed, video consultation. And they're also providing a service which we added on as a sort of opportunity called the Gold Line, which is a 24-hour support coordination service for anybody who's recognised to be in the last year of life who's referred into the service and for their carers. It's mostly a telephone service, but there is a telemedicine element to it as well. Developing plans, the hub is changing sort of monthly really, and at the moment we're just introducing coordination of intermediate care beds and also talking to the CCG about a new model of care for all patients who have complex need, who are thought to be at high risk of hospital admission, so the sort of high risk avoiding admissions patients, and so the sort of top 3% of healthcare users. So that's probably coming quite soon. So telemedicine, as Richard has mentioned, started with prisoners, people with long-term conditions at home. There's now more than 6,000 care home residents in 200 plus care homes across the country, and also palliative care patients at home. We have about 40 palliative care patients with iPads as part of the Gold Line telephone service. So aims of the service on a practical level to support people to stay at home when it's safe to do so, especially out of hours, to support patients and carers and other professionals in the community. Care home staff, sometimes there's one nurse, 30 beds, and they can feel quite vulnerable and isolated, so having another nurse they can call is very helpful for them. It acts as a coordination point. We've been looking a lot in our end-of-life care about cross-boundary care, working with Kyeremateng and the GSF as a cross-boundary care site, and the hub very much sits at the interface between all the different services, with the patient and the hub sort of in the middle of that. If admission to hospital or hospice is required, and some patients do get admitted, obviously, it's a streamlined process. The hub has admitting rights to our local hospitals and can talk to the bed manager and hopefully avoid patients going to A&E, and if possible, send the patient to the ward where they're known, because some of them are obviously known at some wards. And also, what's really been very interesting is the role for the hub in supporting patients and carers while they're waiting for services to arrive, an ambulance maybe, or a district nurse. Particularly in end-of-life care, a lot of people ringing up to report a death, and sometimes very distressed and having to wait an hour or two sometimes for someone to go and actually verify the death. And the hub have been fantastic in providing support to people at that very emotional time for them. I have to say a key enabler for us is System 1, because we're in the very fortunate position that all our GP surgeries and our palliative care services and one of the local hospitals are all sharing the same computer system, and that has been a massive enabler for us. It means that when the hub nurse has full access to the electronic health record of the patient, and we've got an EPACS template within that containing all the key end-of-life information. So as soon as the patient rings, they can pull that information up, and that's in front of them to help them make decisions, and that's absolutely crucial. Obviously, patients have to consent to share their record between services. And when the call is closed, an automatic notification is sent to the GP and all other services involved in the patient's care, letting them know that the hub's been in contact and to look at the record for the details of the consultation which they enter. So just very briefly, telemedicine in care homes has been a very big success, and there's been a lot of work around outcomes, and I haven't got time to go into them in detail, but just to say there has been a significant reduction in non-elective admissions, and particularly A&E attendances from care homes. And it's difficult to quantify, but a conservative estimate is suggesting that for every £1 spent, return investment of £6.82. And now it's happening at scale in care homes that the money invested is providing significant benefit financially. But of course, it's also providing a much better patient experience, much reduced demand on hospital beds and A&E, and increasing deaths in preferred place of care, which I'll talk about again later. So I'm going to move on to talk about the Gold Line, which is more related to the end-of-life patients. So what is it? It's a 24-hour 7 service for any patient thought to be in the last year of life and for their carers. And we are offering a lot of support to carers, interestingly, it seems, as well as to patients. It's linked to entry onto the Gold Standards Framework. We've pushed the Gold Standards Framework a lot in our area across primary care, hospital and care homes, and we've been using that. And the entry point onto Gold Standards is the entry point to the Gold Line. It's mostly a telephone service, as I've said, and started about 20 months ago, so we're still in the early days. But as they say, pictures speak louder than words, so I'm going to show you a short film that tells you a little bit more about the Gold Line.
Running's become really important to me since Bea died. Almost like a form of meditation. And it's helpful because you then are not churning your thoughts around, you are just kind of experiencing yourself.
Thank you for calling Gold Line. If you do not wish for your call to be recorded, please let the nurse know.
I do the night shift about 1 week in 4. Anything to hand over? It is challenging in the way that you never know what call's going to come through. It can be literally somebody just wanting to have a natter in the middle of the night, or you can have very, very distressed people on the other end.
I feel a bit chesty. I could do with a call from a doctor.
Just let me bring your records up.
It might be just me panicking, I don't know, but like I said,
We're having to come to terms that my mother is dying. She's in and out of lucidity. Because there's dementia involved as well, we're not sure.
I think the previous couple of nights that Bea'd been up working hard, she just finished a really big essay that she'd done a great job on, and so she seemed really strong. We were at my mum's house. Bea'd turned to me as we were coming away and said, I think I've lost my appetite. And that was the first sign that there was anything wrong at all. It was innocuous to begin with. They discovered that the breast cancer had returned and it was really quite advanced. We knew it was probably days or weeks.
Our patients potentially have 12 months left to live. The Gold Line number is given to patients, carers and relatives, and that will get you through 24 hours a day, 7 days a week, 365 days a year. You don't have to wait, or you don't have to go to A&E, or you don't have to get your doctor out on an emergency call out.
When Chris had his dialysis,
the wound where the lines had gone in was actually bleeding quite
heavily. When you have that,
you just sort of go numb.
It's like just being frozen in time.
I first met people from the Gold Line while we were still in hospital. Somebody came down to see her and said, look, what's important to you? And she just said, I want to make this as good as possible for my children, and I want to die at home. By the time we got home, they transformed this room, had a bed in it, would raise and lower, and they'd made it look nice. Whoever I rang, day or night, knew exactly who we were, knew all about Bea, and didn't seem to need to look it up on any kind of database. There are about 5 different services that they coordinate, but it never feels that way to the person who's being cared for.
Yeah, and then we've got to make sure that she certainly takes these painkillers regularly for the next 2 to 3 days.
I'll just sit still a little bit.
Yeah.
I'm ever so sorry.
Don't be at all. Don't be at all. That's why we're here. It's much, much worse during the night. People are much more distressed and they're willing to talk about much more the fears and concerns about things. You get the more, I suppose, intimate calls, really, where they're telling you things that probably they won't tell anybody else. A good death for me is ensuring that that person enter that end of life exactly as they wanted to, in the place they wanted to, with the people around them that they want, and it be on their terms.
The night before B died, I could tell that things were very, very different. And I rang them and just said, look, I've never seen anybody die. Would you just tell me what's going to happen? I didn't want it to be a shock for me. I wanted to know what was going to come so that what she would see wouldn't be panic.
I remember the night when Stephen rang in about his wife B, just to make sure that we could get a GP there as quickly as possible so that his children didn't have to see a doctor verifying the mother's death. That became our goal, so that when the children woke up, Mum was there but without doctors around her.
You do need help, you know, you really do. You can't do these things on your own. And I remember I was holding her hand when that happened. And I said to her, you know, don't worry, we'll look after your babies. And that's what I remember, that was very, very tender and very special. And it could have been frightening and shocking.
You look tired, get yourself off. Bye, Chef, it's awful out there, the weather. Okay, good night, sleep well.
At the end of a night shift, you walk out into the daylight from this dark sort of place, having done a rewarding job, despite sometimes it can be quite upsetting and distressing. But you come out into the daylight and it's like, good day's shift done, or a good night's shift done.
I run nearly every day. There's a spot when you get through the top. It takes some effort to get there, but from there I can look across the hills to see where B's buried, which is about 10 miles away. And it's great to be a bit out of breath and just thinking about her. It brings up the happy memories.
So, I hope that gives you a good idea of the sort of service that we're providing and some of the softer stuff around telemedicine and what it enables. So, just let you recover yourselves now, move on with some numbers. So we cover an area, Bradford, Airedale, and a large part of the Yorkshire Dales, which is a 500,000 population, and we aim to offer the service to all patients in the last year of life eligible for the Gold Standards framework, and it's not just for patients named to specialist palliative care, which makes it a little bit different from other helplines that I think people run. Overall aims to support patients to die well in their preferred place, to help carers to support for patients with confidence. And one of the things that Stephen says, who was on the film, is that he didn't use the gold line that much, but just knowing it was there gave him a lot of confidence. It meant he had quite a lot of private time that he wouldn't have otherwise had, just with his wife and children. We wanted to simplify the system for users. Too many numbers, too many services, confusing which ones to ring when, and if you're panicking in the middle of the night, it's just one call, one number. And one of our underlying goals was that patient only ever has to make one call, and then the hub does all the other calls and then coordinates the care for the patient, just says, right, I will sort it, this is what I'm going to do, and I'll call you back and let you know what's going to happen. So improved coordination of care. So why have the gold line? Very quickly, we know that patients in the last year of life are vulnerable, especially out of hours. There's a high risk of hospitalisation. We did an audit of one of our hospitals and found, before we started, on average, people were spending 36 days of their last year of life in hospital, which is clearly not what they want and also expensive. Obviously, they need to spend some time in hospital probably, but we thought we could reduce that. Urgent care services aren't really configured to manage palliative care situations out of hours, and patients have a confusing array of teams to call. Sometimes, and we're finding this a lot, people just want someone to talk to. They don't want a doctor or a nurse to come. They just need some support and some advice and some reassurance. And that really the gold line is providing that no other services do provide. I've mentioned about support whilst waiting for services to attend and helping patients to achieve their preferred place of care and death, usually at home. Key background work, I've talked about System 1, electronic palliative care coordination system within System 1, which we've got up and running, is being key. Lots of work around embedding principles of gold standards framework to get people to identify patients, to put them onto the gold line in the first place, and lots of communication skills training. I think we've trained about 300 staff in Sage and Time, because obviously professionals sometimes find that conversation challenging to identify people. I have to say the gold line is a big enabler about making people have that conversation, because you can't offer someone the gold line without talking to them about gold standards framework, and we give them some supporting information at that time. So it has been a big enabler in terms of getting more people identified as being in last year of life and referred through into gold standards meetings and the gold line service. So how are we doing on identifying patients? So we know that 1% of the population die each year, of which probably 66 to 75% are identifiable. In an area that equates to around 3,500 deaths. Our gold line caseload is going up month by month, and at the moment we've got 1,450 patients. So around 40% of patients in the last year of life in our area are now receiving 24-hour support and being followed through with gold standards framework. So that's great. We want to get higher, and we're doing quite a lot of work embedding it. One of the good things is that we can see by GP practice how many patients are referred, and so we can spot which practices are referring well and which practices aren't really using it. So we're starting to develop some targeted information for GP practices that aren't really using the service as much as they should. At the moment, we're getting about 700 calls per month. So these are on top of the calls that the hub are getting from care home telemedicine calls as well. So they're doing both services together. At the moment, we're quite pleased that we've got nearly half of the patients are non-cancer patients, which is great, and about half not known to specialist palliative care services. So that was one of our aims at the beginning. There's some key information that we want to have in the record to help the nurses to make sensible decisions. So one of the key facts that we want people to have is the GSF reg code. So whereabouts on that last year of life journey is somebody? Are they in the last days, weeks or months? So that the nurse can make more appropriate decisions about the care that might be required. Resuscitation status, there's a status recorded in 79%. That doesn't mean they're all not for resuscitation. It means that someone's had the conversation or doesn't think the conversation is appropriate, but something is recorded in the record. And preferred place of death. There are 3 key facts of information that we really want to have for every single person on the gold line. There's lots more as well within the template that we can add, but they're the sort of key things that the nurses need to help them make the right decision about people. We're having some problems extracting actual place of death data for complicated reasons about record sharing, which I can talk to you about if you want to afterwards. But we've got a solution, but I can't pull that data off yet, but I will be able to soon. So how does it work? Patients are identified as possibly being in the last year of life, and we're working to make that happen in community, hospital and care homes. So it doesn't matter where the patient is. We've been trying to get people to identify them wherever they are. The professional then has, we hope, a sensitive conversation, explains about the aims of the GSF, supported with some literature. Asks for consent for the patient to be part of the GSF and the gold line and to share the patient record. And then an electronic referral is sent as a task through System 1, through the EPACS template to the hub, and then they just accept that record, and that means when the patient rings, the information is there as soon as the nurse pulls up the name on their system. So the year ending in March this year, we'd had 4,648 patients referred, 1,393 deaths, and the average length of time someone was staying on the gold line was 88 days, so probably what sort of thing we would expect. The film said this, that most of the calls are coming out of hours, as you would expect, but still a significant number during the day. Onward referrals. So 39% of calls are managed by the hub themselves. The next biggest group, as you would suggest, that they expect they refer on to is the district nurses, followed by out-of-hours GPs. But they can refer directly to out-of-hours GPs without going via 111, which is great. And they're developing quite a good relationship with the out-of-hours GP centre, so that when they ring and they say, this patient needs you to go now, or this patient needs you to go an hour, they understand that that's really what they need. And a little bit more responsive to it. It's not perfect, and sometimes patients wait, but it's better than it was. So this is just a sample of 2,000, just over 2,000 calls. 91% of patients stayed at home. 6% are reported deaths, so they also sort of stay at home. So there's a tiny admission rate to hospital, hospice, and A&E department, but pretty small. Just a place of death. For patients on the gold line, 14% of patients are dying in hospital, slightly higher than for the specialist palliative care patients, but bearing in mind that half of these patients aren't known to specialist palliative care services, we think that's quite a good figure, and certainly it's reduced over the last 2 years. This is national data. I've got a pointer there. So this is, can't find the pointer. Anyway, the top line, the top blue one, these are deaths in the usual place of residence over the last 4 years at the 31st of March point. So the first, sorry, I can't get this down. The first bullet is 2012, then 13, 14, and 15. So you can see that, so Airedale, Wharfdale and Craven, CCG is the top one. And you can see that over the year since the gold line's been in place, although we were high to start with, we've had a significant rise. The two bottom ones, Bradford, we're also providing the service for Bradford, although we didn't start so soon for them. They're also seeing improvement in the death of usual place of residence. So that's national data, which is quite reassuring. Admissions avoided. It's always really difficult to get this. This is subjective data. When the nurse closes the call, she records what she thinks would have happened if they hadn't called the gold line. Clearly, it's subjective, and we recognise that, but even despite that, there are significant numbers of people avoiding hospital admission, emergency department attendance, and also, interestingly, a significant number of GP and community nurse visits avoided, which is great because those services are very busy, as you know. If you add that, even if you halved those numbers and then multiplied it by the amount of money saved, it still pays for the cost of the service. So video or telephone, these are my reflections. We haven't got hard evidence about this because we haven't got enough patients and we haven't been going for long enough. But video does seem to add value for the patient and the nurse. The telephone's great, but the video does add something extra. The nurses say that they can make more confident decisions about people who ring up when they can see them, as you can imagine. It's quite expensive at present, and I think it has to get cheaper for it to become widespread. But for some examples, breathless patients, particularly the nurses, find it much easier if they can see people and they talk through. They do breathing and relaxation exercises with them, but they can really see and assess them much more easily if they can see them. They get to know the patients quite well because they tend to ring a few times when they start to get ill, so they know what a baseline is, and then they can see if there's a change. We had a patient who couldn't speak. He'd had a laryngectomy and didn't have a voice, but he could write down and he held up cards. This is what I need a whatever. So that was really interesting. We've had a few people who've been, a few patients who've got iPads who are very anxious. Some of them are breathless, but not all of them. And they've significantly reduced their 999 calls and subsequent admissions. And we've got one lady who rings the hub probably 2 or 3 times every day. But her hospital admission rate has plummeted since she's had that option rather than ringing 999, which was her default before that. We had an agitated patient and his wife just went, "Look at him, look what he's doing." And the nurse could see what he was doing and was able to sort of talk her through some techniques to manage the agitation while she was waiting for someone to come and give him some medication. So they're just examples of where the video has worked really well. The other thing is I look after the motor neuron disease patients, and we've been looking for motor neuron disease patients who can't attend our clinic anymore. We've been doing some outpatient consultations from our multidisciplinary clinic through to them at home, and that's been really successful for them as well. So in terms of evaluation, we had an independent qualitative evaluation by Bradford University by Laura Middleton-Green, who's actually a speaker at the conference. If you hear her later on, she'll talk to you about it. She did some qualitative research with patients and carers around the iPad use, and overall very positive feedback, and she's actually called her paper, The Friend in the Corner. That was one of the carers called the iPad for her. It was her friend in the corner who she could call on sort of if she needed some support. We are having an economic evaluation by York Health Economics Consortium, but we've had quite a lot of trouble extracting the relevant data. So it's coming, we're sort of nearly there with it, but we haven't got it yet. In terms of governance and quality, when we first started the palliative care consultants, we audited all the calls for 2 months. We had a look at them and see what, just to make sure that we were comfortable with the advice that the hub nurses were giving. We had very little concern. There is a feedback system for professionals and patients to feedback. There's been a small number of incidents, but nothing so far, fortunately, significant. There's been a few technical issues. And sometimes the Gold Line takes the blame if the GP service has if they're waiting a long time for the GP service. Clearly that's out of our control, but sometimes some of the feedback has been about long waits for GPs to go. We didn't start off with, but we now have a call management system in place, and all the calls are recorded, and we listen to a percentage of calls, of random calls, both for the quality of the welcome and the conversation and the communication skills, and also the clinical advice. And professional feedback forms and patient feedback forms. Here we go.
And I didn't know to talk to you because we're after midnight. So I pressed the button, and the nurse there was very, very helpful, and we discussed my husband's condition, and she thought that he might have an infection somewhere, and she sorted everything out for me. Told me, just keep an eye on him through the night, and if I needed any more help to ring back. She also gave me lots of support. We talked for quite a long time, really, and I felt much better after it all. And I had a good night's sleep, and my husband did as well, but then they contacted me in the morning to see what sort of a night we'd had, and after seeing that, they then arranged for the out-of-hours GP to call, and which if I'd have done that, I would have had to go through the out-of-hours system. So I found that this way we did get a GP out within a few hours to come and see my husband, and the problem was solved with antibiotics after an examination, and within 48 hours they were back to normal again. So it's excellent. It's reassuring, it's like a comfort. Even if you never use it, you know that there's somebody there at the end of that line that can sort things out for you and help you. And whether it's me or my husband, whether it's a medical problem, or whether it's just that you're overwrought and stressed, there's somebody there.
Yeah, it's really, really easy. There's a little button at the side which you press to switch it on. And it's got down here a charge thing. I leave it on charge all the time, so it's always up to 100%. And then at this side, there's a green band and it says call on it. And all you have to do is press the call button, and it's now ringing, and somebody will answer. I'm alright, to you? Not so bad, and he's fine.
I was just going to ask you that next. That's good then. You look well.
Yeah, I'm feeling a lot better. I know. Alright, I'm glad you're there. Alright, love. Bye. Bye.
Okay, so I hope that gives you a flavour of the service that we offer, and I think we're taking questions at the end.
Thank you, Linda.